keynote speaker for 2018 IMSA CME conference. He's had a lot of achievements, and he's been in the IMSA for a very long time and paved the road for the new generations to take over this task of CME program that puts a lot of work behind the scene that really none of us see it until you get involved in it. And there's a long biography for Dr. Shakir that you can read in your booklet. So I have the honor to introduce him as our key keynote speaker for this year. Thank you very much, Dr. Shakir.
Good morning. Good morning. Assalamu alaikum. How's everybody doing this morning? Good? I tell you, it's such a pleasure to come to these meetings. You notice when Imad ibn Asir opened, he said, it's the young generation, there are a few exceptions, and he looks at me. It's hard to imagine how I can ignore that look. But I'm padded by young generation. So youth is infectious. So if I smile a lot, you know, I got a good dose of youth here today. The other thing I want to say is this evening I'm receiving a Lifetime Achievement Award. But almost people say, what's that about? I said, that means you're getting old. But I still am not ready to quit. So maybe I'll get the second one in 20 years, I hope. All right, thank you for being here. I'm happy to share with you. Am I too loud? Can you hear me okay? Okay, I decided not to stand behind the podium, I just walk around. So my topic is the changes in neuroscience. As you all know, not that long ago, shock therapy and psychoanalysis was the way to go in the 1950s and so on. Now I'm going to show you how things have really evolved in the past 20 years or so. So I was going to introduce, I want to just focus on one thing on my introductory slide, which some of you have already discovered, which is the last bullet here. My new career now is being involved helping refugees. So there's a program we started called Care Program for Refugees. I'm happy to introduce Noor and Lucy. Stand up, Noor. Stand up, she's there. And Noor is a medical student at UCSF, and she was involved, we've gone 6 times to work on refugee missions, and once was in Syria, but the past 5 times have been in Amman. And the last trip, Noor was with us, and she has a master's in public health. So she put together some data, and that's a poster presentation. If you haven't looked at it, please spend a minute or two and get the contact information. I know many of you are really eager to be involved. We're happy to get you involved. So that's my other hat. Now I get back to the science. So this is my practice. I'm in Northern California, and we have 5 locations covering the Bay Area, essentially. The logo speaks to the brain, which is what we like to look at: San Francisco, San Jose, East Bay, which is Pleasanton, Mountain View, and Santa Cruz. If you come by, we'll take you on a tour to see the Bay Area. So if I had 2 hours, I'll be covering many things, but I don't have 2 hours. So I'm going to focus on new paradigm in neuroscience, which is localized non-invasive intervention. However, I also want to tell you that our field is advanced in other areas. This, many of you know, is really an era of personalized medicine. That's another area I speak on. I'm going to be in Dubai giving a keynote address on the genetics of pharmacology. That's really important because we all know a lot of people have bad reaction to medications. Now we can use the pharmacogenomic science to target more specifically. It's used in all fields of medicine. Psychiatry is leading the pack because of 55 psychotropics go through the mechanisms of the cytochrome P450. So I'm not going to have time to talk about that or about this, you know, ketamine infusion therapy. We actually do that for refractory depression now. We've been doing it for a couple of years and with some great success, but we don't have to talk about that. And then the other area is revisiting what psychiatry is. Many people stereotype psychoanalysis, shock therapy. It's really what we do now is evidence-based integrative care, which means we look at the whole person, from hormones to medical condition to substance abuse to circuits in the brain to pharmacology, psychotherapy, and try to devise a cost-effective way to treat a patient. So we have a group practice. We have about 40 clinicians in 5 locations. So I'm not going to talk about 1, 2, and 3, only the TMS. So I'd like to show you this. One of the forefathers of medicine is William Osler. William Osler said, the good physician treats the disease, the great physician treats the patient who has the disease. So as medicine gets more specialized, please don't forget the patient when you talk about their right thumb or their wrist injury or their gout. Deal with the patient. So we emphasize looking at the whole person and intervening where necessary. So I'm going to talk about past, present, and future. So past is the 20th century and where we were. Present is the first 2 decades of the 21st century, and the future is the world ahead. So the past is to learn from, not to live in. So please, if you live in the past, you should see me professionally. Depressed people live in the past. You can reminisce, you can have nostalgia, we can have great memories, but don't live in the past. Only honor the past and use it for the present and the future. So in neuroscience, the past really looks at the 20th century, shock therapy and psychoanalysis. Antidepressant entered the market in the 1950s. And then in the 1980s was the Prozac era, the newer antidepressants. And now we're in the 21st century. I'm going to talk about non-pharmacological localized interventions. The Prozac era, you all know this was in the 80s and 90s. There was a big revolution. I know many of you are young and you might have not been practicing, but those of us who practiced in those decades know it was a miracle of Prozac, if you remember that Newsweek article, etc. But not so. Now we know there are some frustrations in pharmacology. So this was based on discovery of neurotransmitters, chemical circuits in the brain, that really prompted the research on serotonin, norepinephrine, dopamine. Of course, I am biased because I'm from the San Francisco Bay Area. I'd like to show you the Golden Gate Bridge here. So this is the Golden Gate Bridge. I use that as a bridge between the mind and the brain. This is where neuroscience has evolved. The mind is in the brain, and we now know about circuits in the brain. So I'm going to not spend time on this part because you all know that. So serotonin circuits are all over the brain. So it starts in the caudal nuclei. So there are billions of synapses that are connected. An imbalance in those circuits can cause disease states. And then there's norepinephrine. Nucleus accumbens is the pleasure area of the brain. Amygdala is an important part. It's a very small part of the brain, but it's where trauma is stored. So when we see the refugees, many of them have an overinflated amygdala because they've had major trauma. And that acts as a precursor for anxiety and depression if you've had trauma issues. And then there's the pleasure neurotransmitter, dopamine, which is focus, concentration, attention, and in neurology, Parkinson. This is the Parkinson pathway. This is the depression pathway. This is the prefrontal focus, attention, concentration, ADHD. And of course, in the ventral tegmental area is where addiction imbalances contribute to addiction and substance abuse. So in spite of all the pathways and medications, do we have, I'm going to ask you, medications, antidepressants that are well tolerated, yes or no? Yes? Well, don't leave the lecture before I finish, because I'm going to show you that many times they don't work, sometimes they cause a lot of side effects, and it really does not always result in recovery. So the study that was done by Charlie Nemiroff from Emory University in the late 20th century looked at all of the patients in the US who are taking antidepressants, and it's not surprising that the results were not that good. Only 18% were optimally treated. That's a disaster. 1 in 5. And there are many reasons. Are they on right medication, right dose, right duration, lack of adherence, lack of efficiency, medical comorbidities, poor tolerability? So this is the climate I was practicing in when I finished my residency. And my subspecialty is mood disorders. So I was saying, help, help, what do we do with those patients? Everybody who's not doing well was ending up in my practice. So thank God I am in Silicon Valley. So technology and engineering really came to the rescue based on brain discovery, which leads me to the present. Where are we at now? The first 20 years of the 21st century. So this is brain imaging has advanced significantly. We can peek into the brain. Remember I said amygdala? This is the amygdala. It's the size of the head of a pin. But now we can identify it based on functional MRI. And then there is structural MRI, which is very helpful. We can look at the hippocampus and see in depression and PTSD, that area can become atrophic. So those are objective findings of disease states. The good news, if you will, around the turn of the century, we discovered BDNF, brain-derived neurotrophic factor, which was beyond serotonin, beyond norepinephrine. It's basically, I call it fertilizer for the neurons. And we now, if you have the right concoction on a cellular level, we can reverse degeneration. This was the first time in neurosciences that you can reverse atrophy of the brain. And it's the mood areas of the brain. So that prompted more research. So how about psychiatry being a systemic issue? Of course it is. We all know if you're under stress, you're going to have more autoimmune issues, you're going to have more stress-related medical illness, and you're going to have premature mortality. Why? Because it affects BDNF in the nervous system, but also affects catecholamines, cytokines, and the HPA axis that you heard about earlier, hypothalamic pituitary axis. And a simple example is a woman who has infertility. She wants to get pregnant, and she's worrying about not being fertile. Guess what? She skips a period, says, yeah, I'm pregnant. 3 days later, she has a period. That's hypothalamically induced amenorrhea. So now, this is the beginning of my real talk, which is the circuits in the brain. Now in the 21st century, we identify, I tell my neurologist friends, the area I specialize in is the prefrontal cortex, which is the mood center of the brain. So this little area here, CG25. What's CG25? Cingulate area 25. It's part of the limbic system. So this whole circuit is the limbic system, which is the mood circuits of the brain. Anxiety, depression. So now we know if we can alter the circuitry in the brain, we can change the disease state. That's what prompted the TMS discovery. So we have a new field, neuromodulation, non-invasive, and that's what I'm going to talk to you about. How did we get into that? You've heard great presentations earlier today on diagnostic MRIs, right? So MRI really changed the spectrum, if you will, from radiology, X-rays, CT, to MRI. There's a funny part to every story. So here's my funny part of the story. This person here, his name is Tony Barker. He's a physicist in Sheffield, England. He was doing research on this machine. This is a magnet, and these are his colleagues. So what he did is he tried to see whether there is any therapeutic value. So he treated this woman with this handheld magnet. So if you want to do the exercise with me, so midway between your left ear and the head is the motor cortex of the right hand. 5.5 centimeters in front of that area is an area about the size of a golf ball, less than 3 centimeters deep. Every time he stimulated that area, this young woman with depression starts giggling. And not in other areas, she started laughing. So he said, we're onto something. Zooming through, this is 1985. This is the device that was FDA studied for and eventually got approved in depression. So I was working at, I finished my training at Stanford, and Stanford was one of the sites of the study. One of my private patients was in the study, and this young woman had failed everything. And 5 weeks later on this trial, her depression is gone. I said, my God, this is not gimmicky, this is not the magnets they were advocating for arthritis and so on. So this is in 2000. Canada approved it in 2003. The US took more studies, of course. In 2008, it got FDA approved. This is the first device approved in the US by the FDA. And at that time, it was the only one. Now we have 5 different companies. That's called the NeuroStar. This is a magnet, this is a chair, this is the control panel, and was FDA approved for depression. So then soon after, in 2013, we got the deep TMS magnet. So we have NeuroStar, we have BrainsWave. In our clinics, we have multiple devices. So then we evolved. More recently, this is called Cloud TMS. This can be paired with MRI-guided intervention. And this is our latest device. It was approved. This actually, do we have any neurosurgeons here? No neurosurgeons. Neurosurgeons, know that that device is approved for preoperative mapping of the brain. It's called Nextin. Last year, a few months ago, it got approved for treatment of depression. So now we acquired one of those machines. It's MRI guided, and we're going to be using it for refractory depression. The APA, American Psychiatric, said, so why are we throwing so many pills at people? Why can't we go to an MRI-guided TMS? So now it is FDA approved if you fail 1 to 4 antidepressants. That's the APA language. So what does it do? It's basically physics. Faraday said when you pass a high-power electrical circuit through a magnet, you generate an electromagnetic field. And you basically tap on the head and with this high-power magnet, and then you basically affect the distribution of connectivity between, so it's not serotonin, norepinephrine, dopamine. You don't have to throw half a dozen pills at someone to achieve those results. So in clinical practice, this is about the first device. This is the position on the head. It's FDA approved. It used to be 40 minutes. Now we have a new improved magnet called the HP magnet, which is 19-minute procedure. So here's what it does. The blue areas are underactive, the red is overactive. Those areas are regulated by serotonin, norepinephrine, dopamine, produced deep in the brain. So I want you to look at the screen. Look what happens when clinical depression sets in. So a lot of the drought in those areas is what contributes to a lot of the symptoms of depression and anxiety. And normally, when we give medication, we're hoping that the medication targets that area, but see what happens here. Unfortunately, we have no control over it, so oftentimes it has a shotgun effect. It goes to other areas of the brain and the body. How many of you have used antidepressants in your clinic? How often do you find patients complaining about weight gain, sexual dysfunction, GI, sleep issues, etc., etc., etc.? So this is why, because you can't really control. Once the pill is swallowed, you can't control where it goes. What TMS does is a targeted approach to the area we localize. I gave you a quick exercise earlier. And we stimulate the neurons, we depolarize and improve release of chemicals in those circuits. But because the brain is heavily wired with billions of synapses, so what you do is you regenerate productivity deep in the pyramidal cells of the brain, producing improved connectivity in those areas. So that's in a nutshell what happens, and in functional MRI, you see improvement in the flow in those areas. So if you look at a depressed person's brain here, and this is the coil, you see the areas that light up pretty quickly. And the protocol varies depending on which device and how long you're treating for. So in summary, we already covered that. So there are pretty much no major contraindication, except if you have cochlear implants, if you have metallic medication pumps, ferromagnetic pacemakers, which nobody uses these days, VNS. If you have history of seizure, head trauma, I usually like to do a full neurological assessment before doing TMS. So now it's included in the American Psychiatric Guidelines, World Federation, Canadian, and Institute of Clinical Systems. So it's widely used. So now let me show you a segment from my own practice. can see a patient here.
No drugs, no side effects, no invasive surgery whatsoever. When medication is no longer enough, some in the Bay Area have found a controversial therapy to treat depression.
So tonight we go in depth on a very personal matter, depression. It affects more than...
Look at the date. It's no longer controversial. That was
provide little relief and a lot of side effects. NBC's Marianne Farmer shows us how some patients here in the Bay Area are turning to a new magnetic therapy to help repel their depression.
First thing we're going to do is position you.
Walt Stever has battled severe depression for 30 years.
When it's not treated, it's terrible. You go into a deep black hole. You don't want to do anything.
That black hole affected his work, family, even his driving. Antidepressants offer moderate relief with many side effects, including headaches, nausea, and dry mouth. After consulting Dr. Shakir in Los Gatos, Walt opted to try a totally different treatment, transcranial magnetic stimulation, or TMS. A small curved device rests on Walt's head and delivers magnetic stimulation directly to a golf ball-sized section of the brain scientists believe helps regulate undergoing the FDA-approved treatment 5 times a week for 5 weeks. Walt says he's a new man.
It's absolutely astonishing what the treatments have achieved.
Because the treatment is localized to the brain, patients avoid the side effects of medications.
No weight gain, sexual dysfunction, fatigue, lethargy, sleeping too much. That's what's remarkable.
Of the patients Dr. Shakir has treated with TMS, more than half have been able to significantly reduce the number of antidepressants they're taking or get off their meds entirely.
So I'm going to skip because we have a lot to cover and I want to stick with the time. So there are now about 650 clinics in the US doing TMS. The yellow is academic centers, the major, Harvard, Stanford, etc. are all doing Illinois, Chicago, all of these, and the blue are private practice sites. And now the world. I'm going to skip Dr. Oz. Dr. Oz had a nice segment, but because of the time, I think we don't have time to get. So we started sharing our data with the rest of the world, and I'm happy to tell you that we've had up to 85% success rates, which is really unheard of with medications. It's for depression and anxiety. So now this one I'm going to show you what happens after TMS. How are you?
Very well.
It's been a while. So I'm glad that you can talk to me today. So I want to ask you a few questions if I may. So this is 2 years after she finished TMS.
Yes.
How long has it been?
About 2.5 years.
2.5 years. So how is life going?
Very well. I'm able to do more things than I used to do. I'm not afraid to try new things and take on more challenges. I'm very careful if a new opportunity arises. My first inclination.
This is a school teacher who was homebound before the treatment.
I love myself, so I think about it carefully and try to keep good work-life balance. And I've been able to take on more projects and basically work more, work at a higher level and longer hours than I had before. And the main thing is I do not get depressed.
Wow.
Even if I get sick or a little bit of anxiety under a very stressful time, that's a normal response, but it doesn't kick over into depression.
What's the difference?
It's night and day because that is what would keep me.
So that's Jane. Then comes the newer technology. So this is the newer device introduced in 2013. This is called Deep TMS. It looks like a football helmet. Somebody said like the old hair dryers that women used to use. It sits over the head. We localize. Same principle, different coil though. Also patented and approved by the FDA. So the difference between the two is non-invasive penetration. So this area is the regular TMS. This is the deep TMS. That's bilateral and deeper, which I'm going to show you what that means clinically. But let me show you a case.
I'm 24. I just graduated from UC Berkeley. It didn't really hit me how having depression till I was around 16, and it didn't get severe until I was 18. And it kind of triggered by like traumatic events and things like that, and it did affect my life. I mean, this is when I was in college, so as much as I went to such a great school and all these things, it would affect my studies. I went through therapy kind of my whole life, and I've tried medications. Medications worked, I mean, initially for maybe a month or so, but then the negative side effects, so like upset stomach, I felt nauseous, overly tired, I hated the side effects, so I would go off of them, and later I wouldn't ever feel better. I would just it would always be ongoing depression. So
Magnetic
nothing
insight.
really helped me.
I was really eager to help her get well. And with my background in training, having been trained in neurology and psychiatry, I knew that this new treatment available, transcranial magnetic stimulation, could be very helpful for this young lady who's tried psychological, behavioral, pharmacological treatment with minimum benefits. So she had already reviewed the information about deep TMS and was very interested in the new device that had just recently been approved, Brainsway Deep TMS. We discussed in detail, got consent, and she signed up for the treatment. To my surprise, that she very early on, within 2-3 sessions, she was already feeling some improvement. So when I saw her in 2 weeks after 10 or 11 treatments, her rating scales were already in remission, which is remarkable. She was giggly, she was dramatically improved. Not believing this is really real.
I had so much more energy, I had motivation to do things, like things that...
So she's doing well 6 years later, 5 years later. So this is a 20-minute procedure, 5 times a week minimum, and then there's an option of continued treatment twice a week up to 3 months. So this is what I want to emphasize. So TMS now is going to be going into other non-depression areas. So both devices are approved. Bipolar, smoking, big thing. Middle East, actually they're targeting smoking cessation with TMS, possibly autism, pain, addiction, PTSD. So stay tuned. It's really which area of the brain we're going to treat. I'm going to show you in the remaining few minutes the new development with targeted TMS. Remember, we started with shock therapy, psychoanalysis. Now we have MRI targeted. So we have 2 devices in our clinics. One is called Cloud TMS, one is called NextStim, which is actually coming literally next week from Finland. It's the newest device. This is the Cloud TMS, so it's basically about the same. The only difference is we combine it with MRI navigation, which I'm going to show you. So this is a group...
Patients suffering from major depressive disorder are severely affected in their daily life. Major depressive disorder can be treated using non-invasive brain stimulation. Brain Science Tools offers the Neural Navigator. In order to improve the accuracy and efficacy of brain stimulation treatment, resulting in improved clinical outcome.
This is the actual
The
MRI.
Neural Navigator is an MRI-guided neuronavigation system which uses the patient's own MRI scan to deliver treatment precisely at the target brain region. The real-time monitoring system allows accurate placement and uninterrupted streaming of the stimulation device.
So this is a company from Netherlands, which I collaborate with, called Neuronal Navigator. Initially it was a research tool primarily, but now we're using it for treatment purposes also. So clinical applications, of course, is depression, trauma, epilepsy, depression and psychosis, tinnitus, Parkinson's, tremor. These are, post-stroke rehab is going to be a huge field. We're going to start using it in post-stroke rehabilitation. This is the last system I want to show you, which is the NextStim. This is a device developed in Holland. Same idea, but I'll show you what it looks like. They have what's called a smart focus MRI TMS treatment. And a picture speaks better than 1,000
A
words.
large and growing number of people suffer from depression, with many not responding to treatment. Nexstim has developed a new method to help relieve depression, transcranial magnetic stimulation, in short, TMS. TMS is an FDA-cleared treatment for depression. It is safe, effective, and has none of the side effects that drugs have. TMS stimulates a part of the brain closely involved in emotion and mood. This increases the activity of the local neurons. Nexstim uniquely personalizes the therapy by targeting the TMS to the patient's own brain anatomy.
This is the motor cortex assessment of the right hand I talked about.
Nexstim TMS provides high-quality depression treatment and allows us to communicate directly with neurons. At Nexstim, we believe it is important.
I think you got the idea. I want to stay within my timeline. And the area, as you can tell, is really exciting. So when my colleague says, are you going to retire soon? I said, why? With this technology going on, hopefully we'll keep on doing it for a long time. So thank you for your attention, and I'd be happy to take questions later on.